the like and the host is the Spice Road Karnataka chapter. The presenter of today's case presentation is Dr. Krishna P. Yeware, the first year postgraduate student from Department of Family Medicine, Trustwell Hospital, Bangalore. And Dr. Saumya B. Ramesh is our moderator, and Dr. Chaitanya Harita also. There isn't much introduction required for Dr. Saumya. She's a consultant in family medicine and medical head at Trustwell Hospital, and serves as also HOD of family medicine. She is the current president of AFPI Karnataka chapter with over 20 years of clinical experience and an experienced faculty, and she trains students at St. John's National Board programs and has delivered public awareness talks across media and institutions. She is deeply committed to patient-centered care and monitoring young doctors. So, hearty welcome, ma'am.
Thank you so much, Spice Root and everyone, for this opportunity.
Dr. Chaitanya Harita is an assistant professor of clinical hematology and bone marrow transplantation at St. John's Medical College Hospital, Bengaluru, with much clinical experience. And his key interests include acute leukemia, stem cell transplantation, myeloproliferative neoplasms, and immune thrombocytopenia. He's a passionate educator. He has received the prestigious Best Teachers Award consecutively for 5 years. And he is an active academic speaker, also serving as faculty for the family medicine distant education program, and he is a keen researcher with the national and international publications and conference presentations. So, Dr. Chaitanya Harita, welcome you, sir.
Thank you so much.
Okay, so hand over to Dr. Krishna. Dr. Krishna, you can carry on with your case presentation. If anything is there, Dr. Saumya and Dr. Chaitanya will be interrupting you in between.
Yes, first of all, thank you, Spice Road, for giving me this opportunity to present case. Very good evening to all. I will start my case presentation. Okay. There is 79-year-old female, it's XYZ. She is a retired supervisor at Bharat Electronics, residing at Bangalore. She is upper middle class by Kuppuswamy scale. She was admitted in our hospital on 10th of January and examined on 11th of January. She came with complaints of swelling in the right side of neck and another swelling in the left side of the neck since 4 weeks. Fever since 3 weeks on and off. Weight loss since 3 weeks. History of present illness. Patient was apparently well 1 month back. Later patient noticed swelling in the right side of neck while seeing in the mirror, while having face wash, and found to have another swelling below the jaw in the left side of neck. Initially, size of peanut gradually progress until it reaches the present size of a lemon, which remained painless during this 4 week. There was no skin changes, no ulcerations, no associated with any difficulty in swallowing and breathing. After 1 week, patient developed fever, which was high in grade. They monitored at home around 101 Fahrenheit to 103 Fahrenheit once in 3 to 4 days. Occasionally as at night, sometimes at day. Not associated with chills, not associated with the rash, malaise, myalgia, or joint pain. No diurnal variation, responding to the medication tablet paracetamol. Patient had weight loss of 4 to 5 kgs gradually, which was non-intentional, associated with the loss of appetite, which was felt by a patient by loosening of clothes. There was no history of any cough, hemoptysis, no history of throat pain, no history of toothache, earache, no history of difficulty in swallowing and difficulty in breathing, no history of discharge through swellings, no history of altered bowel habits and melanoma. Past history. Patient is a known case of hypothyroidism on treatment.
Dr. Krishna, 1 minute. Please go back to your history.
Yes, ma'am.
We would like to ask a few questions as you go on. What was the age of the patient you said?
Yes, ma'am.
Can you please go back? She was around 70 plus, right? 79 years. What is the relevance of age in this case? Why do you think we should think about age? Hello?
Yes, ma'am. Yes, ma'am. Regarding this age, it is a elderly age. Elderly, we know the most common things are malignancy, TB. By that, I asked the history regarding the B symptoms also. Any loss of weight, fever, uh,
Loss of weight,
so
fever, and night sweats, right? Okay. So
night
we are
sweats.
looking at the age because there are some conditions which are more prevalent in elderly age group, commonly being malignancy, and another thing is also TB. So what other conditions you think of if she was a 19-year-old? Suppose she was a 19-year-old who comes with a neck swelling.
19-year-old in young,
Yes.
mostly the swellings are like cystic hygroma, the midline, sometimes thyroid swellings also. It can come in a young age.
Correct.
Goiter, it can come.
Cystic hygroma presents at a very early age, no, as soon sometimes as soon after birth and within 3 to 4 years of life. What other conditions do you think at young age you would think of? I said 19-year-old, 19, 20-year-old. Suppose, and the history is short, maybe 2 weeks, you find multiple nodes, you find that she's running temperature. Yes, as Nurul said, one of the TDs in India is
Acute,
definitely tubercular lymphadenitis. What other conditions you can, like acute lymphadenitis due to any cause, like?
acute lymphadenitis. Yes, ma'am. Acute lymphadenitis. Mm, Any salivary gland swelling, tail of
Yeah,
salivary
if
gland
she
swelling.
comes only with neck swelling, yes, she can have some enlargement of salivary gland or parotitis. Yeah, and even in younger children, mumps is also very common, acute parotitis. Nevertheless, we have also seen
Mumps.
many cases, rising cases of mumps in adults. Okay, okay, go on. Any and also not to forget lymphomas in this particular age group. Dr.
Yes.
Chaitanya, good evening. Sorry, you are free
Good
to
evening, Dr.
interrupt
Saja.
them as and when you want to ask. Okay,
Thank you.
I'm just getting into their basics.
Sure. No, I'd like to, I completely agree with ma'am. The other thing to keep in mind, Dr. Krishna, is, as ma'am mentioned, 19-year-old, whenever you're thinking of DDs, and that's a common thing you'll get in your exam at the end of history, what's your differential diagnosis? It's always good to look at infective, inflammatory, autoimmune, malignant, and miscellaneous. So in your mind, you have those things. As ma'am said, TB is something to keep in mind. Infectious mononucleosis, someone put up in the chat as well,
Yes.
is something that I commonly see as a DD because they have lymphocytosis and certain abnormal lymphocytes in the blood. That's why they get referred to the hemat department. Something to keep in mind. One thing to remember is slightly longer history, maybe 6 8 weeks. Autoimmune lymphadenitis. You may have heard of something called Kikuchi's disease. Generally, the cutoff is 12 weeks, but sometimes we see it as early as 8, is to keep in mind, apart from the normal DDs that you said.
Yeah,
Lymphoma,
and
remember,
also some,
is
yeah,
classically bimodal. So you can have one set of patients presenting at this age, especially Hodgkin's at this age, and one at the age of your actual patient, which is above 60. So lymphoma is across the board to keep in mind.
Yes.
yes. Go on. And why should you know about the socioeconomic status of a patient?
Socioeconomic status will tell the daily lifestyle of the patient and any circumstances regarding that.
Yeah, as somebody is putting, is there any overcrowding,
Overcrowding
chances of
regions,
cross infection is there? And also when you diagnose a patient with particular condition, you're going to offer them your plan of treatment.
plan of
Yeah?
treatment,
So
and
whether
investigation.
they are affordable, where do you plan to send, how do you plan to send, how to make it cost effective and also an effective treatment. And one of the most important key areas of family physicians is doing the right referral. Okay, you're going to guide the patient who is the best and to which expert the patient should go and get connected to that particular specialist. Okay, that from that perspective, and also to know the financial status of the patient, socioeconomic status is very important. Okay, the next slide, please. So you said that there are two swellings, right? One
Yes,
in the
yes,
right side of the neck and another in the left side. You said that patient noticed simultaneously while looking at the mirror. She
yeah.
noticed herself.
Yes, ma'am. She noticed herself
Mhm.
while having face wash. Then another,
Okay.
she palpated on the left side of the neck also. So she
Mhm.
got. Then at same time, she informed her daughter also. So daughter also confirmed the both the swellings are there.
In the history, did you mention that the swelling is only in the neck and not there anywhere else? Do you think this is important? Similar swelling in the neck, swelling in the axilla, swelling in the inguinal
Yes.
region. Yeah, you should
Uh,
mention.
yes, ma'am. Yeah. Yeah, we should look for that for having generalized lymphadenopathy.
And
Uh,
sometimes you should ask patient leading question. Patient would not have appreciated an inguinal lymph node or in the axilla. You should ask a leading question in the history. After noticing in the neck, did you notice elsewhere? Or did you, check your armpit? Did you check your groin region for any such similar swellings on both the sides? It's very important. Okay. Okay. Next. The next slides. What are the conditions where you have a swelling and weight loss? In this particular case, you have a neck swelling and there is weight loss. Just tell us what would be the common conditions where you have swelling and weight loss.
First of all, in India, my most common is TB.
Okay.
Then second, we will go to for lymphoproliferative disorders, means
Wait.
lymphoma.
You said common. So still you can tell common things and then go to lymphomas. I know
Lymphoma.
you have a hematologist who is going to help you, hemato-oncologist. But what other conditions do you think apart from tuberculosis, which there is some swelling which appears to the patient associated with weight loss?
Swelling with weight loss, ma'am. And thyroid gland enlargement means it that leading to dysphagia, loss of appetite.
Correct. Initially, your thyroiditis, okay, common is being Hashimoto's thyroiditis or viral thyroiditis can produce with similar complaints. Okay, patient says that there is a swelling. Actually, there will be, they appreciate the presence of the gland and the associated inflammation. Yes, go on.
And Dr. Krishna, sorry, the weight loss when you get with thyrotoxicosis or hyperthyroidism or even viral thyroiditis is not because of the dysphagia. To get a
Yes.
big goiter compressing the esophagus is obviously very disfiguring. That's usually in MNG. The hypothyroidism itself, because of the high levels of T3, T4 itself, causes the weight loss. But one classical feature is that appetite will be preserved. So they'll have a
More
normal or increased appetite with weight loss. And that's one
correct.
classical feature when you have
More than the dysphagia, I think they complain that there is throat pain.
yes.
We keep checking the throat, and actually you should touch the thyroid gland and see where exactly are they complaining of pain. When you can actually make a clinical diagnosis along with some other conditions like, clinical signs like staring eyes or your tachycardia and sweaty hands and so on and so forth. Okay, okay. So you said that there is a painless swelling in the neck in the history. So can you help us tell some conditions where there is painless swelling in the neck? I'm just asking about only painless swelling in the neck.
Yes, ma'am. Penicillin we will get in TB, lymphoma. Then sometimes we are getting in thyroid gland swellings also,
Yes,
goiter,
like
goiter.
okay, smaller goiter. Okay.
Uh, then thyroglossal cyst.
Okay.
Hmm. Thyroglosal cyst. And sometimes uh, uh, then
People are giving you clues. Sometimes it is just lipoma, there is just
lipoma.
painless swelling in the neck. And it's very common, no? They come to your OPD, they say, Doctor, I'm very worried. There is something happening in my neck. And when you palpate, it's just a lipoma. Sometimes it
Lipoma.
is multiple lipomas. Yes.
Yes.
They can be branchial cyst as well, and which is seen in a
Branchial
relatively younger age group. You said thyroglossal cyst. How do you differentiate thyroglossal cyst from others from history? See, usually thyroglossal cyst is in midline, okay, and it moves with deglutition.
Yeah,
Okay?
midline.
There is another entity which
Yes,
moves
ma'am.
with protrusion of the tongue. What is it?
Protrusion of the thyroglossal cyst.
Okay, fine. Okay, go on.
So
Dr.
just
Chaitanya, anything else you would
yeah.
want
So
to ask?
at this particular point, for you said that it's a painless swelling. Can you tell me some causes where you'll get a painful swelling in the neck? Because those are limited differential diagnosis compared to painless. So anywhere where the patient says it's swollen but also tender, any other causes, any causes that you can?
Yes, sir. Yes, sir. In acute swellings, is there acute lymphadenitis? It can be. In chronic TB abscess, it can be. So it came with means latter.
No,
So
no. Your tubercular abscess is
Yeah,
not painful at all.
it's
It is
cold.
called as a
That's why
cold
cold
abscess.
abscess.
It is
it's
cold
cold. Yeah,
and doesn't show any signs of acute inflammation. Okay.
yeah.
So it is unlikely to be tuberculosis. Okay. Any other swelling, acute lymphadenitis due to what causes? You have to tell
Yes.
me the causes.
Acute viral infections like Epstein-Barr virus infections.
Common things are
Commonest.
your
Acute
mum's, right? Yeah.
acute
And or Ludwig,
tonsillitis.
somebody was telling acute keratitis, Ludwig's
Correct.
angina, relatively common. And sometimes, some infections, like they may have dental caries, they may have some oral lesions that they cause, and some very common is your tonsillitis, right? They
Tonsillitis.
come with very painful
Very painful.
buccal lymph nodes. Okay, so you should think what all the draining areas in the cervical region and how any lesions within the oral cavity. You have yourself written, right, in the history. Go to the next slide. So there are no oral lesions, no dental caries, and so on, right?
So,
So, okay. So, yeah, what other conditions, sir was asking? Acute
Painful.
painful lymph node swelling. What other conditions can cause? Pain is there. Hmm?
So usually, if they come to me with neck swellings, I prefer them to have pain than no pain, because then it's more likely to be benign for me than malignant. So think on that one. And acute conditions, you said lymphadenitis, dental caries, local pain. Anything else can cause an acute lymphadenitis, which is painful. Any other neck swelling which is acutely painful.
Sometimes we have seen no parotitis, but getting drained to the neck. Then there is an extension of diaphysis to the neck, causing pain. And also, we should, yeah. Anything else, doctor?
Yeah. So, sometimes very, very, very rarely that if you have like man said, draining lymph nodes, especially, your retrooropharyngeal areas, especially in
Yes.
elderly people who have infected. Yeah,
Peritons.
those are very common to have. So sometimes the presentation may actually be a painful lymph node, and then when you examine the oral cavity, which is very, very important in cervical lymphadenopathy, you may find the source actually there rather than anywhere else. So important to look at that.
Yeah,
As simple as,
retropharyngeal abscess, sir. That
yes.
Quincy.
No, Quincy is acute
Peritonsillar.
peritonsillar abscess. Acute peritonsillar abscess is Quincy, and it is relatively common than your retropharyngeal or a parapharyngeal abscess. So always remember to open and see and look into the nose, perioral region, examine the dental caries always, look at the tonsils and so on, even in elderly, because tonsillar CAs are also common. Unilateral tonsillar enlargement, always take it with a pinch of salt. And one more thing is, as somebody has pointed out, you also can add, will this neck swelling become painful while chewing or swallowing? They are also contributory. In silidinitis, typically when the patient is chewing, you will have a lot of pain associated with neck swelling. Okay, especially in acute onset. And you have mentioned fever. Can you name
Yes.
some conditions where there is neck swelling and fever? Krishna?
Neck swelling and fever.
Yes.
Yes, ma'am. This might be acute or chronic, ma'am. Acute lymphadenitis. Then it will go to TB, fever. Then neck swelling in the TB, lymphoma. Then lymphoproliferative disorders also, ma'am. In leukemia also.
Okay. Hodgkin's, your filariasis, brucellosis, okay, abscess, okay. You can
Yes,
have remittent or intermittent fevers overlapping with swelling.
fever.
Okay. Okay.
Swelling.
So, any drugs which can cause fever along with neck swelling? Anybody in the
Yes,
group can
drugs.
participate and answer. Okay, just find
Yes.
out. Yeah, what are the drugs which are associated with fever and your neck nodes? Okay, go on. Next.
Weight loss. Third complaint
Weight
was
loss.
weight loss.
Yeah, this wouldn't be gradual, Dr. Krishna, because you had a shorter history of 3 weeks. So this definitely is quite rapid weight loss, and is something to keep in mind, because that's the most sinister symptom when you have such rapid weight loss. The older ANAVA stagings that we used to use for lymphomas, the B symptoms, as ma'am was mentioning earlier, had a time defined, saying 3 months, initially 6 months, and 3 months history of B symptoms. That's removed now, because we've seen rapid weight loss in a month presenting with lymphoma. So this definitely comes under rapid weight loss, which is more alarming for us.
Correct. So this calls for what are the red flags in a patient who comes with neck swelling to you? What are the red flags, Dr. Krishna?
Yes, ma'am. Red flags were the continuous fever. It can be the weight loss, night sweats, and progressively means increasing in nature. Then involvement of the other organs, and involvement of the other site swellings, lymph node swellings.
Oh, so there will be fever and persistent acute weight loss, rapid weight loss. And as sir said, if the lymph nodes are painless, if the swelling is painless, we are more worried, and also associated with B symptoms. And sometimes neck swellings are associated with some compression features, like, stridor or difficulty in swallowing. You are more worried when, especially when it is acute in onset. And these are the red flags which should alert a clinician to investigate the patient aggressively and try to do right reference. Okay. And rapid increase in size. Brilliant. Yes, that's what I just missed telling. Yes, rapid increase in size is also significant. Okay.
Yes.
Next slide.
There was no
I think there is a
With signal issue, Dr. Krishna.
hello.
Yes, sir.
Yeah, go ahead.
Go on.
There was she's a known case of hypothyroidism. She was on treatment of thyroxine 100
Sorry,
microgram daily once.
sorry to interrupt, Dr. Krishna. Can you just show me the negative history in the last slide, please?
Yes, sir.
Okay, you've asked for all of these: cough, hemoptysis, throat pain, difficulty in swallowing, discharge as well. Okay, altered bowel habits, and Marina. Anything else you want to ask? I'm assuming you're asking altered bowel habits and Melina, because you're suspecting CA of the GI tract. Any other negative history
Yes, sir.
that's
Yes, sir.
important when you have neck swellings? Any other history, negative history that's relevant?
Yeah, very important. Yeah.
That means increase in means other organs and
As ma'am mentioned earlier, you
Involvement of
should
other.
ask swellings in other areas. That's important. But if you're
Yes.
suspecting that this is infection, you're suspecting or this is malignancy, anything else you should, any other negative history that becomes important.
Some high risk factors which can contribute to
Yes,
malignancy.
yes, sir. I got any means serology positive means previously in.
How will you ask your
How will you
patient
ask? You
history?
can,
Very
yeah.
important. How will you ask? Will you ask, are you serology positive? You will be looking stars. Tell me, Krishna, how will you ask? Suppose, yeah. One is a contact history. Yes, Sanjana.
Contact history.
Yeah. Anything else, Krishna? How will you ask?
Any previously blood transfusion you have taken?
That is one. Anything else?
So,
You should ask about sexual history, which is very important in this case, right? And also about smoking in India. Smoking, gutka, pan, very important, right? So people, you have seen every movie you go, they show that picture so that you don't forget it. Please don't forget cervical lymph nodes and the high risk factors which can be carcinogenic.
The other thing that you generally ask, in addition to this, exactly what ma'am was saying was what I wanted, but the other thing is if you're suspecting it's a lymphoproliferative disease, lymphoma, or you're suspecting leukemia, we can have this could be a presentation of an elderly acute lymphoblastic leukemia as well. AMLs are less likely to have lymph nodes. The other thing to ask is the symptoms of anemia and thrombocytopenia are extremely important because if the patient also has progressive fatigue, breathlessness on exertion, or evidence of any bleeding tendency, it indicates it's more extensive as a disease, or leukemia is more likely than lymphoma as a presentation. So that's something to also keep in mind. So always ask that history so that you covered most of the systemic involvement.
Yes, that's
yes.
very true. So anemia is very common in India, and when patient is having an acute weight loss, you should ask and quantify how severe the anemia is clinically. Okay. Yes. Go on, go on.
So
Yes.
one important thing to keep in mind is the anemia with thrombocytopenia that you've mentioned in that slide. And this is something that
Yes.
we see often as a reference. So anemia and thrombocytopenia is not a diagnosis. There has to be an etiology behind it. So the patient may say, I had anemia thrombocytopenia, the thrombocytopenia have resolved, but that anemia in an elderly person who now comes to you 2 months later with lymph nodes and weight loss, now that anemia becomes significant. This is exactly why I said it's important to ask, because that anemia could have been a forebringer of anything, not necessarily lymphoma, but malignancy. That's important to ask. The other thing to keep in mind is any person who's on thyroid replacement medication, if they have not checked their TSH frequently, or they've not dose adjusted recently, sometimes can develop high thyrotoxic features because their dose is too much for them. And this is especially common when they've not checked their TSH frequently. So that's another thing to keep in mind for weight loss. Okay.
Yes.
Go ahead.
Family history. No history of TB. No history of malignancy or anything. Menstrual history.
I would not. Sorry,
She
I would not
attained
limit
menopause
it
at
to.
47 years of age.
Wait, Krishna. I think you have to go back to the previous slide.
Yeah, I would not limit it to malignancy related to head and neck, Dr. Krishna, as well.
Yeah.
While you're right about that being the etiology, any malignancy in the family in family history plays an important role. Right? One is lymphomas are
Yes.
generally not familial, but other malignancies which have metastasis can still be there. So it's just enough to say there's no family history of malignancy, but head and neck don't
Any
restrict.
history of malignancy. Yes.
Yeah.
Yes, I will correct. Menstrual history. Menopause at the age, she attained menopause at age of 47 years. No any post menopausal bleeding. Then drug and allergic history. No known history of allergy to any drug or in food. Personal history. She is a vegetarian. Appetite was reduced. She had disturbed sleep. Bowel habits were normal, and urinary incontinence were there.
You have to tell
Case
a little
summary.
bit more about personal history. Please go back. Yeah. So you should tell us that why was the sleep disturbed a bit?
Yeah. Sleep was disturbed because she suffered of the family stress. Recently, she lost her husband due to abdominal malignancy.
Okay.
Okay. So she was getting a fever sometimes in the night and sometimes daytime also, mm, may contributing to disturb sleep.
You said one of your slides said 2 slides back that she was admitted 2 months back with symptoms of UTI, right? How long was she admitted?
Yes.
That
Okay,
history
ma'am.
may have
We
some
work up.
relevance. Hmm.
We work up with routine investigations. We found out she had UTI, urine routine showed pus cells, increased pus cells. So we did urine culture also. It showed E. coli, means culture proven UTI was there. So we treated that, and along with that, she had anemia and thrombocytopenia.
What did you do for that?
And means
Is bicytopenia significant
first we did iron
and
profile we
related to this
did.
case or not? Previous history.
Yeah, it's related, ma'am. The bicytopenia, the thrombocytopenia later get resolved. Then we did a manual platelet counts, so it resolved by the time of discharge.
And the anemia,
Anemia.
But what was the cause? Anemia, was it evaluated? What was the type of anemia? How long was she admitted?
Yeah, anemia we evaluated, ma'am. It was normocytic hypochromic anemia, and she was requesting continuously for the means, discharge. So further evaluation we didn't do, and we told to follow up after 7 days. She didn't came to OPD for about 2 months. So after 2 months, she came back with the neck swelling.
what was the iron profile done at that time, Dr. Krishna?
So there was iron deficiency anemia.
Okay.
Yes.
And the lowest hemoglobin recorded was how much?
It was 8.5, sir. 8.3 to 8.5.
Again, very important, as ma'am said, anemia is one of the commonest diseases hematological in our country. Nutritional being the
Most
leading.
common, sir.
But again, in 8.3 in an elderly woman, iron deficiency is something you cannot neglect, irrespective of especially because she's elderly with iron deficiency. One definite possibility was a GI malignancy causing malabsorption, or iron blood loss is something to consider. So that's another clue that you've had a person who's been with anemia who's then lost weight and come to with neck swellings. All has to be added up. So that adds a very very big differential diagnosis to in the personal history. This is of course an elderly lady.
Just
You
to
also
add on, sorry,
sure,
Dr.
sure, sure.
Chaitanya.
Yes, sir.
See, you said that she came with anemia, UTI, and thrombocytopenia, right? And she also had a short stay and was insisting on discharge on being better. And she never
Yes.
followed up for 2 months. This is a typical scenario in many cases. That's why these cases, as family physicians, we have to follow up. Sometimes patient says, day after tomorrow is somebody's wedding or some function, I need to go, but you need to help them understand the criticality and come back and connect to you, considering what all the red flags this patient had. I would like to emphasize this particular point to all the family physicians. We usually tend to forget the patient after discharge. I think have a diary for yourself where such high risk patients who are prone for some endangering illness, you make a record of it. keep your front office people to follow up this patient. Try to trace and track, what's happening to the patient after an acute episode when they want to forcefully get discharged. And you can also talk to the attenders. I know many a times it is a busy OPD. None of us will have much time. I think, these are the critical areas I think we should start focusing on. Okay, doesn't take much time, but only little. Sometimes I see many of my senior consultants, putting a highlighter, red mark. You can tell the sister, you call back this patient after 1 week and ask her to come back and see me, and they'll do a wonderful job in following up the patients. So this is
I,
one of the tips how to become a better practitioner.
I can't agree with Dr. Samya more. Ma'am hit the nail on the head. Irrespective, any physician, when you've admitted a patient for anything, like a urinary tract infection, which is a benign problem, you found that she's an elderly lady with iron deficiency, right? Follow up is critical. Sometimes the gravity of the disease that they have is something that they don't understand, right? Especially some of our patients who are not as educated may not, understand the depth of what you're trying to say. So initiative from our side to follow up in a week and say you were asked to come back, you haven't. It's important that you get evaluated. May make such a difference to somebody's life, and we've often seen that happen. And however busy your OPDs are, as ma'am said, using like a highlighter or using your front office staff, even your nursing, it takes 30 seconds to a minute to just note it down, but that will make a difference for one life for a person. So I think that's ma'am has hit the nail on the head. That's extremely important for everyone listening, that that one little act makes such a difference.
And this is particularly common with elderly. They are like
Yes.
your premature big babies. They keep
Yes.
doing a lot. They have a lot of resistance to stay back in the hospital.
Yeah.
You have to really counsel the attenders and then the patient, and then the atmosphere becomes a little more conducive for you to,
Yes,
proceed
ma'am.
further. Yeah.
So true.
Okay. Go on.
Anything else in the personal history you wanted to add, Dr. Krishna, that you should ask? Any habits you want to inquire about?
Yes, sir. I missed that, but
Somehow Krishna is
yeah.
with TB and against smoking, alcohol, and all the high-risk behavior.
Yes, sir.
Extremely
Yes,
critical.
sir. There
Please
was.
remember, and one more thing is, as family physicians, we are very, very shy to ask about
Yes.
sexual behavior. I think we should open up, respect the privacy of the patient and try to elicit a proper history, keeping all these things in mind. It's very, very important. Okay.
Yes.
And even drugs, drug abuse, all these things, only when the patient comes and patient sits in front of you at ease with after building some rapport, and you send the attenders out, provided the patient is able to express and tell every personal aspect of it. I think you should take that opportunity and sit and talk to the patient to establish the rapport and confidence. Okay, summarize.
Um, this 79-year-old female, she's a hypothyroid on regular treatment, came with complaints of swelling in the both side of neck, which are painless. Initially, it was size the right swelling. It was size of a peanut. Gradually, it increased to the present size of a lemon, which was associated with the fever on and off, and which was associated with the loss of weight.
Can you modify a bit and make it
Probably you
more
might.
exam oriented, little, polished version? So 79-year-old elderly lady, a known hypothyroid, who on regular treatment for the same, comes with a
Treatment.
progressive, painless swelling on both the
Swelling.
sides of the neck, first noticed on the right side,
Right.
from a pea size to a lemon within 3 to 4 weeks, associated with significant weight loss of 4 to 5 kgs with fever for evaluation. Right. Anything else, Dr. Chaitanya, you would want to add?
So I think where ma'am stressed specifically is that the duration is important. You've said that it's progressed over 3 to 4 weeks. You said fever. You said the quantification of of weight loss in that short period. So that puts across the gravity of what you're trying to imply. And then it makes it now easy to list your differential diagnosis when you put it across.
Okay. We have
Yes.
Lijo, I think we have another 40 minutes.
Yes, ma'am. We
Okay.
can start with the
Yeah.
examination findings.
So my differential are TB lymphadenitis, lymphoma, metastatic cervical lymph nodes, HIV-related lymphadenopathy. My general examination,
Sorry,
she
Dr.
was
Krishna, I would
moderate.
also like to add that, that don't forget the anemia. You've
Yes.
had a very important to add anemia to this because you
Yes.
have, even in your summary, who's been diagnosed with anemia since the last 2 months. It adds a lot of weightage.
To the clinical diagnosis.
Yeah.
Completely.
Yes.
Okay, next go to the general examination.
The general examination. She is a moderately nourished, conscious, well-oriented to time, place person. Pallor was present. No icterus cyanosis clubbing edema. Lymph nodes are palpable in both right and left posterior triangle of knee. Weight 47.8. Initially, at the starting, she was around 52. So
Starting
52.
when? Dr. Krishna?
Sorry.
When was she 52 plus? 52 kg?
52 plus last admission, ma'am. Last admission, 52 plus.
So within, okay.
Yeah. Height 165 centimeter, BMI 17.55, BP 124/74, pulse rate 79 beats per minute, regular saturation 96 on more, respiratory rate 15 beats per minute, and GRBS was 107. So systemic examination, the first per abdominal, it was soft, non-tender, no organomegaly on palpation.
Just 1 minute, Krishna. I have a question. You're talking about neck swellings. Why is systemic examination, especially abdominal examination, important?
First, means any malignancy. First, I want to rule out. First, I will go to means abdomen. So any GI malignancy, any hepatomegaly or splenomegaly.
Why specific reference to liver and spleen with respect to neck nodes?
Ma'am, she had anemia. So previous admission also we know the anemia is there. So hepatosplenomegaly is common in the leukemias, lymphomas.
What are they related? Because they're a part of your reticuloendothelial system.
Reticuloendothelial system.
That's what you're trying to assess, whether the other systems are other parts of the components of the reticuloendothelial system are affected. Okay. So what is the relevance of jaundice and neck swelling?
Just go back to your previous slide.
We have a lot of questions on.
Yeah, jaundice, because you didn't mention no icterus, so importance.
Yeah, there was no icterus.
Yes.
Jaundice, bilirubinemia.
Relation to, ma'am was asking, you have
what is the relation?
Lymph nodes. You also find them to be icteric. Can you put 2 and 2 together?
Hepatocellular carcinoma, one can be there.
How frequently you see it? Tell me something more common.
Also, point to note that HCC presenting as jaundice
is unlikely.
It's only about 15 to 20% of HCCs actually come with jaundice. So something more common.
Okay. Sometimes you find some nodes in the neck, and when you see the patient is ectric, and when you palpate also inside the abdomen, you find the lumps. So direct clue. What is the importance of Virchow's lymph nodes? Virchow's.
Yes, ma'am. Left supraclavicular lymph nodes.
Okay, where all it is palpable?
These are palpable
significant
abdominal malignancies.
Which malignancies? CAS tunnel is one of the commonest. And by the time patient comes to you, already there are distant mets within the liver. Actually, liver primary malignancy, as sir said, the yield with jaundice is very less. Usually the metastatic varieties with metastasis into the liver and is when you pick up these nodes with icterus and swelling. Any hematological condition, sir is next to you. Dijo says others can also answer. Yes, they are answering.
I think Dr. Krishna, ma'am was asking hematological disorders where you can get multiple lymph nodes and jaundice, something you should keep in mind.
Sorry.
Others can answer. This is very important, you know. And it's the first thing is if the patient is very pale, it's very challenging sometimes to pick up icterus, especially unless it is a deep jaundice. Okay, you need a good lighting, and really you have to look into other parts. Nuruddin Bohraji, I just asked where you get icterus with palpable lymph nodes in the neck. What are your DDs? Okay, especially hematological conditions.
If you think of the differential diagnosis that you spoke about, Dr. Krishna, earlier on, you said lymphoma was one DD. So you can have lymph nodes in the neck, you can have lymph nodes in the porta hepatis, compressive symptoms. Some types of lymphomas can also infiltrate the liver directly. There's something called the hepatosplenic T cell lymphoma, which presents in younger adults, males. Very, very bad prognosis, but they can have. You can have T cell lymphomas and B cell lymphomas compressing the porta hepatis. It's usually bad. Leukemias as well, especially acute lymphoblastic leukemia. There is a common, we see them, maybe about 18 to 20% of adults have liver infiltration. So whenever you see the combination of lymph nodes and jaundice, you should keep your, awareness that these are very strong possibilities.
Okay.
I just want so you mentioned that she's moderately nourished and you have a BMI of 17.55. Anything else you want to think of when you say moderately nourished?
Below.
You understood where I'm going with the question, right? You said 17.55 is the BMI, an elderly lady who's got significant weight loss, but you're saying moderately nourished. Now, if you had to defend yourself, and I would say she's poorly nourished because of the underlying cachectic state if she's got a malignancy. Any argument that, how would you justify?
Yes. Previously, she was healthy previously, sir, but
Correct.
recently.
Yes, so recently she's lost weight.
Yes,
And you're
sir.
saying
Yes,
that
sir.
BMI has dropped very.
Yes, it's
Yes,
an
sir.
acute
She
weight
dropped.
loss. So body is not shown up chronic features. That's what sir is trying to
Yes.
intuit,
Yeah.
right?
Yes, sir. Yes, sir. Yes, sir.
You're going to describe the lymph nodes subsequently, I guess, right?
Yes,
Yes,
sir.
yes, yes. We'll go to local examination.
I
Yes.
just had one more question. You also mentioned edema. Can you tell me where else specifically when you got cervical lymph nodes you want to look for edema? Your obvious answer is not going to be the lower limb edema. Think and tell me where you would look for edema when you've got a patient who's got cervical lymph nodes and anemia.
In thyroid glands.
Just think, where would you get edema? So you're saying virtuous lymph node is palpable, left
Yes.
supraclavicular. Can you get a person with upper limb edema?
Upper limb, lymphadenitis, you can get, sir.
Lymphadenitis, upper limb bed, you will not get
Upper
upper
limb
edema.
edema, where do you get?
Say, let's say it's unilateral. You've got a
Yeah.
left virtuous lower, you've got the node here, and your left upper limb is also
carcinoma breast also. Carcinoma breast.
Okay,
Carcinoma
more than that.
breast per se?
No.
No. It is probably post-mastectomy after surgery. There will be destruction of the lymphatic regions. Okay. So you should
But
think, where else
again,
unilateral lymphedema? I mean, sorry. Yeah, unilateral edema. That is giving a lot of clues.
it's important, especially if you've got a big lymph node mass in the neck, you got unilateral edemas. It's compressing something. No? And the ma'am gave you a clue earlier saying virtuose is also
Yes.
that. So virtuose is where the thoracic duct opens, right? So the thoracic duct drains all the lymphatics from the abdomen and the one part of the thoracic cavity directly into the subclavian vein behind the clavicle. So let's say you have a big mass there. Can you think of anything it can compress, which can cause upper limb swelling? Your subclavian vein. So let's say you got the subclavian vein draining behind the clavicle. Large lymph nodes can compress those veins and they can present with unilateral edema. The second thing to look for in a patient who's got cervical lymph nodes, suspecting malignancy, is when they have facial puffiness. So let's say they've come with a congested face, eyes are congested, neck veins are very prominent.
Pemberton.
What is the diagnosis?
Pemberton syndrome.
Pemberton is the sign.
Is one of
Sign.
them.
Pemberton
Yeah, one of the
signs.
signs.
But what is
Thorax
the
syndrome.
SVC obstruction?
Thorax.
Very good.
Not thoracic outlet, Dr. Krishna, superior vena cava obstruction.
Superior vena cava obstruction.
Yeah, so one of the things to check when you have cervical lymph nodes is if there's a mediastinal nodes mass, especially in something called primary mediastinal B cell lymphoma, or even lung metastasis, they can cause SVC obstruction, and that can commonly present with edema. So important in cervical lymphadenopathy to keep these two things especially in mind. Okay.
Along with the edema, there is a lot of condition, especially in fair-skinned individuals. So you should make out a fair red edematous face with upper limb swelling. You should think of SVC obstruction. Now coming to local examination.
Local examination.
Sorry, one thing, you go back to systemic examination, please. You mentioned about abdomen, and I agree with ma'am. Hepatosplenomegaly is important to know. Any lymph nodes you can palpate in the abdomen? Can you tell me which group of lymph nodes that you can palpate while doing an abdominal examination? Ma'am had already mentioned it earlier.
Sir, yes. First, we'll go for inguinal and iliac.
Okay. Fair enough. Anything else? Inguinal is absolutely very, very important.
Yes, and left supraclavicular.
Okay. No, abdominal I'm asking. So
Only
inguinal is
abdomen.
important because often, as ma'am mentioned, women may not be as forthcoming to tell you or probably notice an inguinal lymph node as much. It's important to palpate. Anything else which group of lymph nodes is palpable by the paraortic? Good. So paraortic lymph nodes just above and lateral to the umbilicus is generally how we palpate. If this was a gentleman, what else would you have palpated? Answer is quite obvious.
Gentleman, Krishna.
Ilioinguinal.
It's there in women as well. What is specific? I specifically had the same history in a 20-year-old boy.
Yes, sir. I got in men. Yes.
What else below the inguinal? Just go down, no? The clues are obvious.
Femoral. No, sir.
Think slightly medial to the femoral. Can present as a painless swelling of the what? Painless swelling somewhere, generalized lymphadenopathy, and your diagnosis is leukemia. Testicular swelling.
Testicular, yes, sir.
Very important. If a patient, either elderly or young, you're suspecting either lymphoma or METs. So if you've got inguinal lymph nodes, femoral lymph nodes, as you mentioned, very important to check the testis. Ideally, some people also say that you should check the prostate in elderly, which generally is not a common practice. But in a younger individual, if you're suspecting lymphoma, leukemia in a young male, testicular swelling is absolutely normal. This is often asymptomatic because it's a painless scrotal testicular swelling. It's important to do. Can you tell me one point in CVS, RS, and CNS that you should check in your case that you looked for, which may have helped your diagnosis?
Yes, sir. In RS, we'll decrease breath sounds, decrease air entry. To rule out, sir, any lung pathologies, lung carcinomas.
Than carcinomas.
Yeah.
Krishna ji, you are
First,
so fond of,
TB.
yeah, first
First,
is TB.
TB. TB. In our country, that's the default answer for most DDs would be you have to make sure that you've checked for TB, especially so upper lobe cavitary lesions. It's important to check.
Cavity.
Of course, your reduced air entry for a pleural effusion can occur in malignancy, and you can have a lung mass as well. But TB is particularly important to keep in mind.
Yes,
Okay.
sir. In CNS, we'll find for focal deficits,
Like,
compression lesions.
no. Which deficit you would, we are very specifically asking. So CNS and cervical lymphadenopathy, what are your relevant clinical findings which you would want to explore or examine in the patient?
Uh, Ma'am, ability to speak means irreverent speech is there or not?
Sorry, we couldn't hear.
Then uh, ability to speak.
No, I'm not asking CNS
Sometimes
examination.
irrelevant speech
Yeah,
will be
Vandana
there
is right. Cranial nerve
if
examination is very important because,
compressing
especially in
lesion are
tubercular
there.
meningitis, they present with headaches and sometimes diplopia, and basal meningitis, especially, they have some cranial
Blurring.
nerve palsies, and sometimes signs of meningeal irritation will be there. Though meningitis per se in advanced stages, but signs of meningeal irritation or meningism is sometimes obvious. And when you have a history of headache, neck swelling, and your ocular, signs of
Swelling
cranial
of
nerve
chin.
palsies, the many a times in our country, the diagnosis is very obvious. So, anything else? If there are occipital nodes and you would want to think about in India, of
Uh,
late, this condition is on rise.
in occipital nodes are most common in syphilis, secondary syphilis.
Yes,
Most
secondary
common.
syphilis. Yeah. And of late, the number of pickups are high in India. And anything else, if you get a post-auricular lymph node, which is a part of posterior lymph nodes, post-auricular lymphadenopathy, you will be more worried if she's pregnant lady who is unvaccinated. That is a direct clue. So rubella, you should be very cautious and careful about, especially they
Rubella.
produce your post-auricular lymphadenopathy. Yes, Nuruddin is right. It is rubella.
Rubella.
The other thing, Dr. Krishna, you mentioned about, so let's say you have a elderly gentleman who's got cervical lymphadenopathy, anemia, unexplained, and you notice that he's got partial ptosis. You've also noticed partial ptosis. He's got a left supraclavicular lymph node. He's got left-sided partial ptosis. Anything else you'd like to consider?
That means, sir, cranial nerve involvement, third nerve involvement, partial.
Partial ptosis,
Partial.
not
Somebody has
complete.
got an answer.
So, where do you get partial ptosis, meiosis, relative enough loss of cerebrospinal reflex? Those are all the components of which syndrome?
Yes.
Horner syndrome. Have you heard of Horner syndrome?
Horner. Many are right. Obviously, Vandana, all of you are right.
So that's something to also look for in the CNS examination, especially when you have cervical lymphadenopathy. Ma'am had mentioned earlier, some always check the oral cavity for oral CA, because sometimes it's very neglected in our country because they'll have chronic ulcers, they'll just neglect it. Sometimes they can have a 12th nerve palsy as well because of infiltration, the hypoglossal. It's important to check the low cranial nerves for any reason when you have a cervical lymphadenopathy. Okay, you can go to the lymph node exam.
Lymph node examination. Patient examined with due consent under adequate illumination in supine and sitting position in presence of female attendant. On inspection, first diffuse swelling with ill-defined border, approximately of size 2 into 3 in the right submandibular region in anterior angle of neck, and another in the of size 2 into 2 centimeter in the left submandibular region. Overlying skin is normal and healthy. No visible scar sinuses was present. It was non-pulsatile, no dilated veins, no movement on deglutition and protrusion of tongue, no tracheal deviation.
Which are the examples of neck with pulsatile swelling?
Neck with pulsatile carotid body tumor.
Okay. And any swelling over
carotid
here?
artery aneurysm.
Carotid artery aneurysm.
Aneurysm.
Then you can hear the bruit. Yeah.
Right.
And what is the relevance of sinus in neck swelling? Sinuses are scars in neck swelling or axillary swelling.
In sinuses in the abscess and lymphadenitis, it is common lymphadenitis and then in the abscess scars will be there in it.
Because formation of a sinus tract in an abscess generally is not so common in the lymph nodes unless it's grossly untreated. But that's something to look at. Anything else when you have a sinus? What you're worried about? Okay, let's say you do have a sinus from a lymph node, which is the most likely etiology?
Lymphadenitis.
Due to which?
TB. You've been talking about TB and suddenly we made you conscious of tuberculosis. You forgot about it. So please never forget TB.
Never.
It's very,
Never.
very important. Residents also please note that always when you have an unwell patient and it's not an easy diagnosis, keep TB in the background and never forget it. You may have many supportive tests which you can do. Actually, you should always get a microbiological confirmation for your diagnosis, but you have some supportive test also which will tell you. But never ever forget TB in India. Make it a dictum always to document whether you like it or not. No history of TB or contact with TB or history of TB previously in this patient. Okay, many a times you will get surprisingly good results, especially when you want to pick up some EPTB, extrapulmonary TB cases. Deviation. Name one swelling.
Sorry, ma'am, I didn't got.
I think ma'am's screen is frozen. Which level of so you notice a swelling in the submandibular region apart from lymph node? Siluritis is something to keep in
Yes.
mind. It could be a salivary gland tumor. Can you tell me any diseases which causes bilateral painless salivary gland enlargement? Something to keep in mind.
Mumps, sorry, sir, can be unilateral.
Submandibular salivary gland, painless swell. Bilateral.
Tonsillitis, sir, acute tonsil.
Submandibular swell.
Submandibular, sorry. Submandibular.
You have the submandibular salivary glands. So let's
Yes,
say
sir,
your
yes,
salivary
sir.
glands are enlarged, painless, bilateral. In a lady, you should always suspect Sjogren's syndrome.
Sjogren's.
Very important to keep in mind, Sjogren's. Okay. Now ma'am is back. Okay. Ma'am was asking you something, Krishna.
Yeah. No, I just asked when there is tracheal deviation, when there is retraction of the trachea, there is a mediastinal shift, and you should think of some mediastinal or surrounding lesions which can cause. Sometimes it is, tubercular pleural effusion, unilateral predominant, usually unilateral it is. And sometimes you have your, fibrous lung, causing pull of the trachea to the same side. So always try to examine where could be the lesion depending on the involvement of mediastinal structures. And always touch the patient. I would want to emphasize on this, though it is a spice route teaching session. I hardly see residents touching the patient, feeling the pulse. Always believe in your personal examination. Do not document what sister has written pulse, what sister has written saturation. And it's always nice when you feel the pulse, when you touch the patient for any temperature rise, when you locally examine the patient, especially if they have sinus, wear a glove and please, examine the patient, but always be and get involved and actively examine the patient. Don't look at the reports first. Sorry for that bit of deviation.
No, ma'am is absolutely right. At the end of the day, while you get your scans and your investigations and etc., there's one and only one person that you have to trust finally to come to a diagnosis, and that's yourself. So unless you've done a full thorough examination, just relying on reports is not enough. You have to be convinced yourself. You have to examine the patient thoroughly. Next slide, Dr. Krishna.
Next slide.
Palpation. Inspectory findings confirmed. Swelling of size 3 into 2 centimeter felt in the right submandibular region, and another swelling of size 2 into 2 felt in the left submandibular region. They are mobile and firm in consistency. There is no local rise in temperature. They are non-tender, non-fluctuant, non-compressible, non-reducible, and non-transluminant.
Okay, can you tell some swelling in the neck which are soft for examination when you touch? The consistency is soft.
Soft is abscesses. Any abscesses and cystic swellings are soft.
Is thyroglossal cyst soft?
No, that is exception.
That is an exception.
Thyroglossal cyst. No.
Okay.
No.
Okay. What else? Lipomas, no? Multiple lipomas in the neck. Yes, and what one clinical sign will help you to differentiate? Yes, it is lipoma and nothing else. What is that sign? Slip sign, right? Okay. So keep all these clinical pearls in mind.
Slip sign.
Your hands are best to diagnose and your brains, not the reports, right? Okay. We have discussed about local rise in temperature, fluctuant swellings, fluctuating inconsistency.
Fluctuant, most common example is lipoma.
I would not agree with lipoma.
Yeah, that is not a term you'll say that. We don't generally say lipoma as a fluctuant swelling.
You yourself said non-fluctuant. So tell me at least one swelling where you pick up fluctuation. This is how we get into trouble even in exams. Always lead the examiner to things which you know. Yes, abscess, very important. Right? Any localized abscess gives you a fluctuant nature of the swelling. Where you get compressible swelling, compresses, disappears.
Yes. In a cystic hygroma.
Yeah, cystic hygroma.
The compressible, then.
Yes. Anything else?
Then, ma'am, other hernia swellings.
Okay. Hernia in the neck, unlikely.
No, and abdomen.
Okay, non-reducible swelling, dermoid cyst. Yes, sometimes you even get, but there are some varieties of dermoids and teratomas hard. So it depends on what is the underlying pathology. Okay, go on.
I just had a couple of questions, Dr. Krishna. I'm sorry. You said soft, ma'am had asked soft consistency. Obviously, if you get a hard consistency, you're worried about malignancy. What is the type of consistency of lymph nodes in syphilis? What is the classical description given to syphilitic lymphadenopathy and lymphomatous lymphoma? What is the description given? They're mainly in the books, but something to keep in mind.
It is rubbery.
In lymphomas?
Lymphoma, rubbery.
Is rubbery. In syphilis? Anybody in the audience? Shorty.
Shorty. It's called shorty lymphadenopathy.
Yeah, Roshni is correct.
And the one thing to especially in lymphoma to understand is that it's not always hard. though it's a malignancy itself, it's usually rubbery. And classically in chronic lymphocytic leukemia, CLL, which we see in elderly patients at this age, the lymph nodes actually will, when you squeeze the lymph node when you're palpating, they will actually feel like rubber. Classically, you feel it in CLL. It's a very easy way to pick up CLL lymphadenopathy. It's important. So rubbery and shorty are things to keep in mind. Okay.
Oral examination. Missing teeth was present in the upper and lower jaw, mostly premolars and molars. No mouth ulcer, that's instant. No mouth ulcer, no dental caries, no tongue coating was there, and no inflamed tonsils were present in oral examination.
Anything else that you would have liked to look at?
The
One is in the
diagnosis.
tonsil itself. You said inflamed tonsils. I would also say there is no tonsillar enlargement. Sometimes when you have Waldeyer ring involvement, you can have tonsillar enlargement as part of a lymphomatous process, sometimes as part of infectious mononucleosis in younger individuals. It's important, not just inflamed tonsil, any tonsillar enlargement.
Enlargement.
Since you're also suspecting that one possibility is, you mentioned mouth ulcers as well. So it's important to also look for any, especially in the cheek, inner cheek as well. Yeah. Or in the gingival sulcus as well. A lot of elderly people can have a malignancy sitting quietly there. So it's important to check.
And please look at any erythroplakias, leukoplakias,
Leukoplakia.
important. Sometimes non-healing ulcers. You may think it is aphthous ulcer. Carefully examine and if required, get a biopsy done.
Yes.
And whenever you see a non-healing oral ulcer, it can be a small, dental repeated trauma causing non-healing ulcer. But always try to feel for the lymph node, and if you feel it's suspicious, always try to get a biopsy done. One dictum for family physicians: any skin lesion, if you cannot identify what it is, take specialist help, get the necessary biopsy done before you start the patient on any steroids, especially or antibiotics. Do not give steroids unless you pick up a tissue specimen. Please try to remember this. Wow. And indirect clues, the patient is a chronic smoker, but not telling you truth is the nicotine stain sometimes, and the teeth will be, the lips will be brown in color. Okay. These are very important. As you observe the patient, you will start picking up all this.
These are my differentials: tuberculous lymphadenitis, lymphoproliferative disorders, metastatic secondaries from oral cavity, larynx, or thyroid.
Okay. But a couple of other conditions, sir also had suggested, no? You can put lower down like Kikuchi's or even Castleman's as a lower down diagnosis.
I would still mention those as well. I would also keep especially elderly leukemia is still something I would keep in. And while you're saying met stuff and oral cavity larynx and thyroid, again, papillary CA, follicular CA, okay, but I would also keep GA malignancies. If she's had anemia, prior to this. So I would also mention, and never forget to also mention HIV. Acute HIV infection can present with a transient 6-week type of viral type of fever, lymphadenopathy, which resolves on its own, and then many years later turn out to be HIV positive. Acute HIV infections are something I would also keep in mind.
So as sir said, infective, it can be inflammatory, it can be malignancy, it can be autoimmune. Try to establish that stream of thought and try to put it in your DDs.
Yes. Okay. So we evaluated this patient. So hemoglobin we found out 10.9. Total count were normal 5,730. Platelet was 73,000. Sodium was slightly less, 134. Potassium 4.8. Creatinine was normal, 0.8. Then liver function test was normal, except albumin was less, 3.1. Globulin was higher. So
Just
reversal
1
of
minute. Why do you want to get an LDH done in this patient?
LDH. This ma'am for any malignancy as a indirect marker.
What other marker you would want to rely on in such cases?
LDH.
Which are indirect markers?
Yeah.
Ferritin.
Yes. What is a significant ferritin level in malignancies? Suppose if it is a hematological malignancy. What is that? Is if your lab upper limit is 250, is 300 a significant ferritin level in this case, or is 500 a significant ferritin? What would be considered as a significant ferritin level, which is a marker of acute phase reaction? That's what I'm asking.
More than 3 times.
See, we usually take it as around more than 1,000. Correct me if I'm wrong.
Thousands.
Yeah. So more than
Absolutely.
1,000 we consider as an indirect acute inflammatory marker, and you would want to look into the patient keenly. Just consider the supportives like LDH and also uric acid into consideration. But considering this age, many people we come with cardiac failure and uric acid, you can't take it as the one of the reliable markers, because even in cardiac failure, uric acid will get elevated. Okay, and various other conditions apart from your renal failure and things like that. AG ratio. What is the relevance of AG ratio and cervical lymphadenopathy in this case? Why are these markers? We hardly look into very, very important indirect clue. MM. What is MM? I don't know. Okay, yeah.
Multiple
Autoimmune
myeloma mostly.
In fact, autoimmune condition
Autoimmune.
is 100%
Multiple
react.
myeloma.
Very good.
Hmm.
So one thing to also keep in mind is while myeloma doesn't generally present with very, very rarely presents with lymphadenopathy, some of
Yes,
the
yes.
lymphomas that you have can actually have a gamma globulin an M band like myeloma, like especially some types of lymphoma. The other two conditions in our practice where we get referrals saying, oh, AG reversal rule out myeloma is actually TB and HIV. They usually have AG reversal. So that's another clue that tells you that you have something which is a systemic inflammatory issue. Okay.
Then we did a peripheral smear. It was showing normocytic hypochromic anemia with mild eosinophilia. So on manual platelet count, it was showing 1.30 lakhs per cubic millimeter.
It's very important for us to ask a
Then we
peripheral
test.
smear in all the cases. Please note. Please ask a complete blood count. I've seen many consultants asking only HB, saying cost-effective patient. We are not doing any justice if we do not have a complete blood count with the peripheral smear. It is always CBC with peripheral blood smear. It is a Pandora's box. It can give us a hell lot of diagnosis, and this is the most cost effective strategy. Nobody is asking you to do autoimmune profile, myeloma profile. Yes, we will have indirect markers to do all that, but always make it a habit to write complete blood count with peripheral blood smear. Okay, very, very important.
Ma'am is absolutely right. I just like to add a point. Any of my residents and the medicine MD medicine students or who was posted with us, no hemoglobin can be reported, or you cannot report anemia without peripheral smear, without RBC indices, without a reticulocyte count. If you don't have these, there is no point trying to report a peripheral smear. So asking for hemoglobin isolated with MAMSA doesn't make sense. CBC with peripheral smear is a bare minimum. And I think everyone should know that it just makes life easier and helps you go down the right diagnostic.
I remember one patient, coming to attend another patient's condition, elderly. And we just said, uncle, you are looking pale. Why don't you just get a CBC with peripheral smear done? And it turned out to be an ALL patient. So, I mean, it's very surprising, but a simple test can pick up the diagnosis. Okay.
Absolutely.
It was disappointing, but at least we could pick up, and the patient is still doing very well. Okay, you have your
So
thyroid, PT, INR.
thyroid,
Okay.
yeah, CRP was negative. So those thyroid was overcorrected. So we adjusted the dose. Then we did lymph node biopsy
Ah,
of right cervical lymph node. So we sent for gene expert. It came negative for TB
before that, first you need a specimen, right? For either gene expert or
specimen.
your FNAC or your biopsy. When do you want to ask for an FNAC? When do you actually ask for a biopsy? And if biopsy, what is the specific type of biopsy which you ask? It's very, very important.
Yes,
All
ma'am.
of you, please note
First,
this is something which you have to remember and learn. Okay. Yeah.
first, ma'am, we have to means confirm that is the lymph node. Then after
Yes.
confirming it is a lymph node, we have to do FNAC. The first investigation, first line investigation, FNAC.
Suppose, see,
Then
FNAC you
FNAC is
only ask.
showing means
Wait,
suggestive.
Dr. Krishna.
Dr. Krishna,
F
yeah.
FNAC you only ask when it is dash, and you directly go for an excision biopsy when it is dash. Very important.
Then biopsy.
Please do not, if you are doubtful about the node, if you are only sure of TB, ask for an FNAC. If you are doubtful about the node, please ask for an excision biopsy.
Excision biopsy.
We cannot, why is this differentiation very important? Please interrupt me and correct me anywhere, sir.
No.
Why is this differentiation very important? That you ask for an excision biopsy in case of a doubtful node, especially in this clinical scenario. You're not sure that it is TB, right? You are suspecting, yes, the yield is very important, and you're going to take the entire biopsy specimen. At least it should be a minimum of 1 centimeter by 1 centimeter. It should be minimum, and half of it, preferably you get 2 specimen. We are very happy because you're doing an excision biopsy. It will be under anesthesia, and try to send 1 specimen for histopathology. 1 specimen you try to put in normal saline. When you send for histopathology, the specimen has to be adequate. It cannot be a tiny cutie piece and you pester your pathologist, give me a diagnosis, give me a diagnosis. Your FNAC becomes useless when it is suspected malignancy or any other lymphoproliferative disorder. A better biopsy specimen will definitely give a good yield. Okay, and always when you're suspecting TB, whether you like it or not, you send 1 specimen in normal saline for MGIT and liquid culture to rule out tuberculosis, especially in our country. Okay, so specimen collection is very important. They are very precious specimens. You can't do it day in and day out. And when you ask for an FNAC, be very careful in case of tubercular lymphadenitis. We say yes, FNAC justified, but you're a little bit doubtful about the lymph node. Please ask for excision biopsy, because in future, when we send to Dr. Chaitanya, he would want to do IHC markers, he would want to do further investigations on this particular specimen, and we need a good specimen for it. Okay. Please remember this point, and please add on anything else which I missed out.
I absolutely agree, ma'am. So the only reason I generally don't ever ask for an FNAC in my practice. But as ma'am said, the only probably 2 places I would do it is I'm pretty much convinced it's TB. I just need microbiological proof that there is something to tell me that it's TB. Or in swellings where we are not sure of the source. If I'm not sure if it's a lymph node or it's say pus collection, cyst, etc., then maybe an FNAC to just tell you what it is. But apart from that, the only 2 biopsies I do, we do an excision biopsy because I need, as ma'am said, the whole lymph node to be removed. I will do, grossing of the lymph node. We will do basic histopathology and IHC markers. And IHC markers are a must, and I need enough tissue for that. The second thing that we started to do, not really for cervical lymphadenopathy, but for certain other tough lymph nodes to access, is interventional radiology does a true cut biopsy, CT guided or ultrasound guided. And you know what? The minimum number of samples they need to take from a true cut biopsy is sometimes 10 to 12. They take multiple cores because they have to take it from multiple areas in the lymph node. And if it's a slightly bigger lymph node, the IR team actually does an ultrasound, looks at where there's the corticomedullary differentiation within the lymph node and takes it from there because the yield is best. So it's very important to know excision biopsy is key. Unless you're very, as ma'am said, strongly convinced that it is TB.
And always don't just ask for a test. Write a good history to the consultant histopathologist. Get
Yes.
connected to them, to your pathologist, to your microbiologist, and then send your specimen. It becomes very, very important to get connected. They should also have a good clinical picture what's happening to your patient. And lab is not a different. I always say it's not Pakistan or China. You don't have to differentiate them. You just have to get connected so that your yield is better, right? And always when you send for histopathology, you get a diagnosis. As MBBS graduates, we used to run to the lab to see what's happening inside the microscope. You should enjoy doing all that. Then only you will start learning it in a better
Yeah.
way. Okay. Yes, Krishna. So your gene expert was not detected. So you're disappointed. You went on telling TB, TB, TB. Are you disappointed that your tubercular lymph node gene expert is negative? Can it still be TB? That's what is my question. So you did at FNAC, you sent for gene expert. It said negative. Does it completely rule out tubercular lymphadenitis? No.
No,
What
no, ma'am.
else
It
you should
can.
do? What else you should do? You're right. What else you should do? So whenever you get a gene expert
Um,
negative, yeah, always have another specimen in normal saline, send it for liquid culture along with your histopathology. The gold standard,
90%.
yeah, the gold standard in TB lymphadenitis is a culture negativity. Okay.
Yes.
Unless you get a negative culture, you need not say that patient does not have TB. Sometimes you may have tuberculosis coexisting with lymphoma because it's also an immunocompromised state. So always think like this. And also, um, you should know that your lymph node sensitivity through your gene expert can be somewhere around 85%. But sometimes your MGIT sensitivity can be low, somewhere between 25 to 70%. But culture is the gold standard. If you get a caseating granuloma, it doesn't mean it is 100% TB. The converse is also, please remember things. And whenever in doubt, put them along with PCR for cultures. Gene expert positive आ गया तो yes 100% TB. Negative आ गया, it is a headache. Never forget that it cannot be, TB can't be ruled out. Just put it into cultures. Okay. And
Yeah.
liquid culture through backtech within 3 weeks you'll get the result. Please
Yes.
remember this. And all government will IRL labs will do it free of cost. Yes, it is. We are talking only about TB lymphadenitis. For other cultures also, you have to,
Yes. Okay.
other specimens also, you have to put it for culture. Okay. The flow line is gene expert. First is AFB smear. If you don't have it as open case, then your gene expert, then your linear probe assay, which is compulsory, and then the culture. Okay. One specimen goes for culture, one goes for LPA assay. Okay, along with your gene expert. It's for all the specimen as per NTP guidelines. Okay. And always do HIV testing. You may pick up multiple conditions in a single patient. I'm sure, I think Dr. Chaitanya would have seen
Yes.
all of it.
Yes.
Yeah. Okay. Next. I think we are running short of time. Sorry.
Then we did a PET CT for to find out any other involvement, other lymph node involvement. So it was showing multiple metabolically and conglomerate lymph nodes involving bilateral, cervical, supraclavicular, axillary, few abdominal, and pelvic lymphadenopathy. So it was likely to represent as lymphomatous lesion, and they told excision biopsy correlation of right axillary.
Something important to notice here is that sometimes what you get clinically may have just been lymph nodes in the cervical region. But if you when you do the PET, you'll find that there's a supraclavicular, there's axillary, there is pelvic, there are multiple lymph nodes that you may find, which is why a PET CT scan
Pelvic.
staging is always important. One
And
thing I say that
also
you
sometimes a fussy patient, who is not getting convinced for excision biopsy, actually
yes,
do a PET and show them it is spread everywhere. They will get convinced most of the time, and they'll be
very
obliging.
much so. The other important thing for PET is there are three things which are very important in PET. Ma'am has already alluded to one, that sometimes you need to convince a fussy patient. Second, nowadays all staging are done through the dual staging on a PET scan, right? We follow the Ann Arbor and then the dual staging. Third, very important thing is when I have generalized lymphadenopathy, which is not, say, extremely, large lymph nodes, then we look at the SUV, that is the uptake on a PET scan. And that will tell me which lymph node is the most avid, meaning the SUV uptake is highest in that it's taking up the fluorescent dye the most. That tells me that my yield when I do an excision biopsy will be highest from that lymph node. If you notice here, they've written excision biopsy correlation from the right axillary node. How do they figure that out? Because that particular lymph node is lighting up the most in a PET. So there are three reasons why a PET would rail. Okay.
So this histopathological examination came up. So it showed lymph reveals the idiopathic multicentric Castleman disease.
Can you go back to the description, please, Dr. Krishna?
This one, sir.
Okay. And the final.
Remark. So what sir is trying to help you all understand is never look at the final diagnosis. Read at every line, every word in your report. You will understand it a little more better. Make it a habit. We all are short of time. We want to jump, see what the final diagnosis is. Sometimes there can be mismatch when you can actually discuss with the lab team and also refine the diagnosis. I think that is what we all should develop it as a habit.
Absolutely. Every biopsy has to be discussed. So the pathologist will give they're looking at one tissue under a microscope. This is their diagnosis. But you as the clinician are looking at the patient as a whole. Your pathologist is giving you a tissue diagnosis. Your radiologist is giving you an imaging diagnosis. But you are the one who has to put them all together. So without discussion, unilateral decisions will always, be tough. It's always better to discuss what are you suspecting, what are they suspecting, and then come to a conclusion. So that's how it should be done. So that you said the diagnosis was multicentric Castleman's, correct?
Yes.
Yes, sir.
Oh, got it. So, like I said,
Multicentric
it's
Castleman.
if you presented this case to me, say either as your final exam in university or as a hematology resident presenting, and you had said Castleman's as the first DD, I would have said you've read the file. Impossible. So there is, because Castleman's is a disease that is picked up purely on histopathology. There's no real way to suspect it because it mimics any type of LP. So your thought process, don't worry that your diagnosis you didn't think of as a DD in the beginning. Though ma'am mentioned Castleman's in the middle, your thought process is lymphoproliferative disease, infection, inflammation, it still fits, right? So there are these rare syndromes, idiopathic multiple carcinoma,
Yes.
there's something called IgG4 disease, Kikuchi's, Kimura. There's so many things which are rare. That the final diagnosis is not critical. It is important about your approach and how you've reached that diagnosis. That's important.
So just for the benefit of audience, a little bit about Castleman's, if you can tell them what is it and how do we manage.
It's a
Chaitanya
rare
sir.
disease.
No. I want to hear from the expert, Chaitanya sir.
Okay, so Castleman's is it doesn't really come under the hematological malignancy type of disorder. It used to. Now they've put it under immune mediated and inflammatory types of disorders. So you have mainly two types that we generally look at. You have unicentric Castleman's disease and you have multicentric Castleman's disease. So it's not an autoimmune disease, but it's an autoinflammatory or inflammatory disease, which basically presents with fever, night sweats, lymphadenopathy. Most patients who are unicentric Castleman's are generally picked up on a biopsy. And if it's unicentric, there is no multisystemic involvement. Pure observation is required. And sometimes when you've done the excision biopsy itself, you relieve the symptoms. Those are usually just kept under observation. Multicentric Castleman means they have multiple areas of involvement. They can have hepatosplenomegaly, they can present with lymphadenopathy, pyrexia of unknown origin, mediastinal involvement. Rarely they can present with also polyserositis, ascites, pleural effusion, pericardial effusion, and they can be quite sick. But that's only about 5-10% of these type of multicentric Castlemans. Now, under multicentric Castlemans, there's a slightly newer classification which we start using, where they can be associated with something called Poem syndrome, which we've learned as a plasma cell dyscrasia, and then you have HHV8 related Castlemans, and then you have idiopathic multicentric Castleman's disease. So here they've said idiopathic because there's no HHV8 and there's no osteosclerotic lesions on the PET scan, so they've ruled out Poem syndrome. So the treatment depends. If it's unicentric, your excision biopsy is enough, sometimes just observation. Multicentric Castleman's generally requires treatment. They do beautifully well with a short course of steroids. But if there are compressive symptoms where you have polyserositis, then we tend to treat them more aggressively, usually steroids with a combination, sometimes with rituximab, B-cell monoclonal antibody against CD20. Very rarely they are so sick and so much disease that they've gone with multi-organ dysfunction. We give chemotherapy. So rituximab, cyclophosphamide, vincristine, prednisone, RCVP is sometimes used to debulk the disease. So these are the usual ways in which we treat them. Nowadays in India, rituximab is being replaced. There's a drug called siltuximab, which is used. Extremely expensive, difficult to procure. So we still stick to rituximab, steroids, and supportive therapy. The problem is 30 to 50% of them tend to relapse. So those are patients that you need to look out for.
So overall, the prognosis is much better than lymphomas. If
Definitely.
you put it that way.
Yes, ma'am. Absolutely.
Okay, I think Dr. Chaitanya, Dr. Krishna has done justice to his presentation.
Yes.
Good case and lot of inputs in. And thank you, Dr. Chaitanya, sir. You have been wonderful in adding a lot of value to our discussion. I think residents are also happy and a lot of chats regarding the same. I'm glad that the session was very useful to them. That's all we need at the end of the day. I think over to Lito.
Thank you. Thank you so much, Dr. Swami. I'm very, very happy that I got to chair this session and share it with you. And well done, Dr. Krishna. I know it was it's something that you commonly see in your practice, but I thought you encapsulated it very well. And I hope all the residents listening got those few 5-6 truly important points that ma'am and I was stressing on. It just improves the overall quality of care that we are all getting.
So we are running short of time, but still we have 30 plus participants.
No, I just saw 45 10 minutes back. So I was very happy later.
We had almost 70 plus participants.
Yes.
Yeah, we sincerely thank our esteemed moderators, Dr. Saumya and our expert specialist, Dr. Chaitanya Harita, for their expert guidance, insightful moderation, and valuable academic perspectives, which we have to take in our daily clinics. And though we were running out of time, they were so enthusiastic to teach us, and a heartfelt appreciation to the presenter, Dr. Krishna, for a clear, engaging, and well-presented academic session. And thank you for all the participants for making this session enriching, interactive, and truly impactful. Thank you, one and all. Good night.
Thank you, Spice Route. All the best for such good initiatives.
Thank you, Lijo. Thank you, Lijo. Thank you, Karnataka chapter of Spice Route. Thank you, Soumya, ma'am.
Thank you. Thank you, Vishnu.
Very nice session. Thanks.
Thank you, everyone. Thank you, everyone. Take care. Good night.
Thank you.